Okay. Okay. Done. Okay, guys, welcome back. Now we are going close. Okay, welcome back, guys. Now let's begin with the renal pathology. Okay, so in last class, I hope we have completed the gastrointestinal pathology. Now, from today, let's do the renal pathology, sir. Okay, now you know, right? In renal pathology, you need to know the congenital anomalies. Okay, after that, the most important topics are the nephrotic syndrome and nephritic syndromes. Okay, nephrotic syndromes and nephritic syndromes, these are the most important topics that you should know from renal pathology, right? Having said that, now let's begin from the basics. Okay, good evening, everyone. Good evening. Panmod, Ashutosh, everyone are there? Good evening. Praveen Shiva, Vanilla GMC, Gopi. Yeah, let's do. So the first congenital anomaly that we are going to discuss is an unilateral renal agenesis. What exactly is unilateral renal agenesis? Unilateral renal agenesis means one kidney is absent. Okay, one kidney is absent and not formed. Okay, one kidney is not formed. Okay, so what happens if there is, yeah, good evening, fun mode. What happens if kidney is not going to be there, not formed? Okay, is it going to cause death in the baby? Will it kill the baby? No, it's compatible with life. So the baby is going to, like, you know, there is no problem is going to be there for the baby, but some problems will be there, but it is compatible with life. It's not incompatible with life. The baby is not going to die for sure. It's compatible with life. Okay, but look, right, bilateral renal agenesis. Bilateral renal agenesis is incompatible with life. Incompatible with life. Which means if both the kidneys are absent, means definitely the baby is not going to live. Definitely the baby is going to die for sure, right? Now, which kidney is going to be most commonly most commonly going to be absent? Left kidney, usually. Left kidney is going to be absent. Usually left kidney is going to be absent, sir. When the left kidney is going to be absent, now all the work is going to be done by the right kidney. So there is going to be compensatory hyperplasia seen in the right kidney. Okay? Compensatory hyperplasia in right kidney. Okay, right kidney. Okay, hyperplasia, sir. Okay, that's okay, good. Sir, if all the work is done by the right kidney, now all the work is going to be done by the right kidney, sir. True. Now, in the right kidney, will it be affected or not? Yes. If all the work is done by the right kidney, yes, that kidney is going to be little affected, little damaged. So, glomerulosclerosis is going to be seen, sir. In this right kidney, what you look under the microscope is, so under microscopy, there will be glomerulosclerosis. Okay, glomerulosclerosis is seen under the microscope. Okay, so this kidney, right kidney is at a risk. Now this right kidney it's at a risk of renal failure. Okay, why? Because all the work is done by the one kidney, right kidney. So the right kidney is at a risk of chronic renal failure. Okay. Now my questions to you: what are the problems if one kidney is absent? Okay, unilateral renal agenesis is one kidney is absent. What are the problems, sir? Look, let me write the problems one by one. See, when one kidney is not there, the baby is going to produce less urine, right? Okay, the baby, imagine this is the baby. Now the baby is inside the uterus. Now baby is not at born, the baby is inside the uterus. This baby is not having one kidney. So the baby is going to produce less urine. So if the baby is producing less urine, in the mom, there will be oligohydramnios. Okay, the amniotic fluid is nothing but the baby's urine. The baby's urine is nothing but the amniotic fluid. The baby is not having one kidney. So less urine production, less amniotic fluid. So oligohydramnios, the baby is going to have oligohydramnios. Okay, so oligohydramnios is going to be seen. Oligohydramnios means what? Less amniotic fluid. Okay, less amniotic fluid. When the less amniotic fluid is there, now what happens? What's wrong? See, normally the amniotic fluid is the one which goes into the fetal lungs. It goes actually, the amniotic fluid is the one which helps in the fetal lung development, sir. It helps in the lung development. As there is oligohydramnios, so do you think that in this baby lung development is going to be normal? No, there will be pulmonary hypoplasia also. Pulmonary hypoplasia, not formed properly. Okay. So because of less amniotic fluid, there will be pulmonary hypoplasia. Hypoplasia, so pulmonary hypoplasia. You can clearly see here. See, these are the lungs. Lungs are not properly developed. Lung is not properly developed. Okay, whenever there is oligohydramnios, there will be pulmonary hypoplasia. Normally, the baby is very happily swimming in amniotic fluid. Okay, the baby is happily swimming. It's doing the pool party. But whenever the amniotic fluid is not there, what happens? Now the baby is going to be compressed. The baby is going to be compressed against the wall of the uterus. Imagine this is the wall of the uterus. Now there is no fluids and no proper amount of amniotic fluid. So this uterine wall, it is going to compress the face of the baby. Okay. Now there is no proper space for the baby development. So limb abnormalities can be there. The baby is not going to have the proper limb formation. Limb defects will be seen. The baby is going to have flat face. The baby's face is going to be compressed against the wall of the uterus. Flat face. So that ears will go down, low set ears. Okay. So due to this less amniotic fluid, oligohydramnios, there will be pulmonary hypoplasia. The baby is going to have flat face, low set ears. Okay, low set ears are going to be seen. Along with that, the patient is also going to have small chin. Okay, micrognathia. Okay, and limb defects. Okay, see the baby is having a flat face, almost a flat face. Okay, flat face. Now, what is this? All this together called as, okay, pulmonary hypoplasia, flat face, low set ears, all this together called as Porter sequence. Porter sequence. See this Porter sequence, it's a consequence or it's a complication of oligohydramnios. In the Porter sequence, what are going to be there? The patient is going to have pulmonary hypoplasia, flat face, low set ears, micrognathia and the limb defects. Okay, limb defects. Okay, these are the points which I want you to know. So apart from this, what else you should know regarding the congenital anomalies? One congenital anomaly is unilateral renal agenesis. One kidney is gone. So that Porter sequence is going to be seen because of oligohydramnios, pulmonary hypoplasia. Okay, sir. Now look here and tell me, what is the problem? What is the problem, sir? Here you can very clearly see that the kidneys are attached. Now they don't want to separate, so they are inseparable kidneys. The kidneys are attached in their lower pole. So if you look at the kidneys are looking like a horseshoe. You know that horseshoe, right? So these are the horseshoe kidneys. For your exams, what you should know regarding the horseshoe kidney? So normally kidneys are formed in the pelvis. Kidneys are formed in the pelvic region. Now they usually ascend up, sir. Both the kidneys, they form in the pelvis. Now they ascend up. There is ascension of the kidneys. Okay, there is ascension of the kidneys into the abdomen. But when you having such kind of a kidney, okay, see what is this? Now here the lower poles are fused. Lower poles are fused. Now when these kidneys, when they are ascending up, whenever there is an ascension, see this artery, there is this one artery which will not allow the further ascension. So that artery is going to cause a blockage. Now these kidneys cannot ascend up. So what is that artery? It's the inferior mesenteric artery. Okay, so inferior mesenteric artery is the one which preventing the ascension of this horseshoe shaped kidney, horseshoe kidney. Okay, so write one by one important points. Horseshoe kidney is the most common congenital renal anomaly. Congenital renal anomaly. Okay, it's the most common congenital renal anomaly, sir. Now, what is happening here? There is a fusion of fusion of lower poles of kidneys. This is the second important point which I want you to know. Next, here how the kidneys are going to look like. The kidneys are going to look like a U shape, that you already know it. But what is the important point? The failure of ascension of the kidneys is due to, okay, failure, ascension of kidneys is due to what? It is due to inferior mesenteric artery. Inferior mesenteric artery is the one which prevents the ascension of the kidneys, IMA, right? Inferior mesenteric artery. Done, sir. So these are some important questions which I want you to know. Apart from this, which individuals are going to have this, which individuals are going to develop this horseshoe shaped kidney? It's going to be seen associated with, sir, it is associated with the chromosomal disorders, sir. It is associated with the chromosomal disorders like Edward syndrome, okay, Edward syndrome, you know, right? Trisomy 18, Downs, okay, Down syndrome. So Down syndrome is trisomy 21, and Turner syndrome. Okay, Turner syndrome is 45x0, complete 1x is gone. So these individuals may develop the horseshoe shaped kidneys, are important. Now, when you do radiological examination, so these patients are going to have what kind of radiological appearance? Guys, do you know? Any idea? Say radiological features. Come on, guys. Come on, fun mode. What are the radiological appearances that are seen in these patients? What are the radiological appearances that are seen in these patients? Intravenous urogram is going to show what kind of appearance. See, for your easy understanding, see, look how it's looking like. So these are the ureters. Okay, see, the kidneys are fused, right? In the lower ports, the kidneys are fused, right? So the ureters are also coming closer together. So it's looking like a flower vase. Okay, flower vase ureters. Okay, so now what kind of radiological appearance is going to be seen is flower vase, okay, appearance. Flower vase appearance of ureters. Okay, flower vase appearance, and this is also called as hand joining shine. Okay, hand joining sign. Okay, hand joining. Both the kidneys are fused, right? So hand joining sign is seen. Okay, for your exam purpose, this is important. Flower vase appearance of the ureters. Flower vase appearance of the ureters is seen in horseshoe kidney. Horseshoe kidney. Okay, done, sir. Next, what else you should know? Sir, normally kidneys are present where? Kidneys are present in the abdomen. Okay, kidneys are present in the abdomen, sir. You know it. But if the kidney is present in the pelvic brim, what if the kidney is present in the pelvic brim, sir? It's not in its original place. It's in some other place. So these are called as ectopic kidneys. Okay, ectopic kidneys. What is the most common kidney that is involved? The most common kidney that is involved is left kidney. Okay, most common kidney that is involved is left kidney, sir. What is the most common abnormal location? The most common abnormal location is going to be pelvic brim. So kidney is going to locate in the pelvic brim. Okay, pelvic brim, not in the abdomen. Now kidney is present in the pelvic brim. Okay, so these kidneys, these ectopic kidneys, they are associated with the ureteral obstruction. Ureters are going to be obstructed because of such ectopic kidneys, and that can lead to infections. Okay, that can lead to the urinary tract infections, sir. Okay, most common kidney involved is left kidney, in ectopic kidney. Okay, what is the most common site? Pelvic brim. Now after this, let me show you one more condition which is also going to be there. Okay, which is not going to be there from the birth, but anyway, guys, can you tell me what is this disease? Can you guys tell me what is this disease? The disease which I am showing you right now. Fun mode. Limbraj, Renuka, Praveen, Siva, Vanilla. Come on, guys, be active. Come on, guys. Can you tell me what is that kidney that I am showing you? Who will answer first? Any idea? Okay. I think, yes. Vanilla, you are true. One more, you are also partially true. Vanilla is precisely correct. This is polycystic kidney disease. How many types of polycystic kidney disease are there? Okay, how many types of polycystic kidney disease are there? See, first of all, the polycystic kidney disease is an inherited disorder, sir. Inherited disorder. Yes, it's an inherited disorder. Okay, it's an inherited disorder. As it is inherited disorder, genes are involved, right? As it is inherited disorder, so it's going to be bilateral in nature or unilateral in nature? It's going to be bilateral, very, very important. It's always bilateral in nature. Okay, both the kidneys will be affected, bilateral in nature, sir. Okay, how many types are there? There are two types. What are they? Yes, there are autosomal dominant, AD, autosomal dominant polycystic kidney disease, ADPKD, and autosomal recessive polycystic kidney disease. Okay, autosomal dominant polycystic kidney disease, autosomal recessive polycystic kidney disease. There are two types. Okay, now whatever I am showing you here, see, it's a big kidney, so the kidney is totally enlarged, and you can see all this, like, cysts, right? These cysts. Now tell me, is it ADPKD or ARPKD? Now when you are having such a macro, macro level cyst, the cyst you can see with the eye, and there is total enlargement of the kidney. Now the kidney is almost the size of this ball. Now tell me, what is this? Sir, when you see such kind of big cysts with your eye, with the kidney enlargement, definitely it is ADPKD, sir. Autosomal dominant polycystic kidney disease. In autosomal recessive polycystic kidney disease, yes, cysts are there, but small cysts are seen. Okay, small size cysts are going to be seen. Okay, that we will discuss one by one. So, important points: polycystic kidney disease, inherited disorder. Okay, inherited disorder, bilateral in nature. Both the kidneys are going to be affected. It's of two types: ADPKD as well as ARPKD. Right? Now, first let's discuss about ARPKD, sir. Autosomal recessive polycystic kidney disease. I have explained you. The cysts are going to be there, but no kidney enlargement, not too much enlargement of the kidney. Small size cyst. Dekho. Here. Sir, these are the kidneys. See how beautiful they are with the small cysts. You can see the small cysts, not the super big cyst. Okay, see, small cysts are seen. Okay, you can see, right? Okay, this is autosomal recessive polycystic kidney disease. So, right, first AR stands for here, autosomal recessive, autosomal recessive polycystic kidney disease, PKD. Okay, polycystic, multiple cysts are there in the kidney. Now, question is, why the cysts? What's the problem, sir? Inherited disorder, so genes are involved. What is the gene that is involved in the ARPKD, guys? What is the gene? It's the PKHD1 gene, PKHD1. Okay, so the PKHD1 gene, it is mutated. It is located where? Sir, it's located on chromosome number 6p. Okay, on chromosome number 6, chromosome 6, P arm, short arm. So this PKHD1 gene, it is mutated, sir. Gaya. So when this gene is mutated, what is the protein that's going to be affected? Sir, this is a gene mutation. When this gene is mutated, okay, so some protein will also be affected, right? So what is the protein that's affected? Fibrocystin. So fibrocystin is the protein that is going to be defective in this condition. Okay, fibrocystin is the protein that is going to be affected. So when this protein is affected, fibrocystin, so the patient is going to have which symptoms? What are the manifestations that are going to be seen in the patient? So the manifestations you already know. So the kidney involvement is going to be there. Okay, kidney involvement is going to be there. So kidney, what do you have? Cysts. Okay, liver involvement will also be there. Liver is also going to show the cysts. So multiple cysts in autosomal recessive polycystic kidney disease. Not only kidneys are affected, but also liver is affected. Not only the renal cyst, extra-renal cysts are also present in the liver. Okay, so liver will be affected with hepatic cysts as well as hepatic fibrosis will be seen. Okay, hepatic cysts and hepatic fibrosis is going to be seen, sir. Now, what is the gross morphology of the kidneys? The gross morphology of the kidneys is going to be smooth kidneys, sir, not too much enlarged. Okay, of course, enlarged. Kidneys are enlarged, no doubt. Not too much enlarged like autosomal dominant polycystic kidney disease. Enlarged but smooth kidneys. Okay. Now, these patients, what they are going to have? So, these kidneys are not functional, not like normal kidneys, sir. Okay, they are not functioning normally. So, imagine there is a baby. Imagine there is a baby. Okay, for example, okay, there is this one baby, sir. Imagine, let's take this baby. Now, this baby is having autosomal recessive polycystic kidney disease. Now, the kidneys are functioning normally. The kidneys are not functioning normally. So, when this baby is in the uterus, when the baby is in the uterus, the baby is going to produce less urine. So, oligohydramnios is going to be seen. So, this baby, okay, is also going to cause oligohydramnios during in utero. The baby is going to cause oligohydramnios in the mother. Oligohydramnios. Oligohydramnios is going to be seen. Whenever there is oligohydramnios, which sequence is going to occur? Flat face, low set ears, micrognathia, pulmonary hypoplasia, limb defects. That's a Porter sequence. Porter sequence is going to occur, sir. Not only that, these kidneys are defective kidneys. Okay, so proper glomerular filtration rate is not going to be there. Oligouria, less urine production. So because of that, in these patients, these kidneys, the RAS pathway is going to be activated. Okay, these patients are going to have activation of the RAS pathway. Okay, these patients, okay, due to the renal failure, these patients may have the activation of the RAS pathway that will lead to the hypertension. Okay, these patients, RAS pathway is activated, that can lead to the hypertension in these babies. Okay. Yes, of course. Yes, of course. Both the kidneys you are going to have the cyst. In both the kidneys you are going to have the cyst. Bilateral nature, so no doubt, bilateral nature. Both the kidneys you are going to have this. Okay. So cysts are going to be seen in the kidneys as well as liver. See, now you can understand there is hepatic fibrosis going on. In the liver there is cysts. Okay, they are hepatic fibrosis is there. Whenever there is hepatic fibrosis as a consequence, see, my liver is undergoing fibrosis, hepatic fibrosis. Whenever the liver is undergoing hepatic fibrosis, all the blood vessels which are going through the liver are going to be compressed. So what happens? Now what happens to the portal veins? Portal hypertension. So because of this hepatic fibrosis, the patient can even develop portal hypertension, sir. True. Portal hypertension can be seen because of the hepatic fibrosis, not because of oligohydramnios. Okay, oligohydramnios is going to show the Porter sequence. Okay, so now tell me what are the important points that you should know regarding the autosomal recessive polycystic kidney disease. PKHD1 gene mutation. PKHD is present on chromosome number 6. What is the protein that is coding by PKHD1? It's the fibrocystin. Because of the defect in the fibrocystin, the patient is going to have the cysts in liver as well as the kidney. The liver cysts are going to be seen as well as the cysts are going to be seen in the kidney. Cysts are seen, but they are not big cysts, they are small cysts. So the kidney is going to be smooth. Okay, the kidney is going to be smooth. Next important point is, sir, because of the involvement of the liver, there will be hepatic fibrosis. That hepatic fibrosis can even lead to portal hypertension. And so the kidneys are not going to function normally. So there will be oligouria, less amount of urine production, that will lead to oligohydramnios in the mother. Whenever there is oligohydramnios, I have explained you, there will be Porter sequence. Porter sequence is going to be seen. And these babies also develops the hypertension. These babies also develop the clinical features of hypertension, sir. Renal failure, that's leading to the hypertension. Okay. So after this, what else you should know? Okay. I have explained you everything. Okay. Next, is it going to be good prognosis or bad prognosis? So the prognosis is going to be good or bad? This autosomal recessive polycystic kidney disease. Prognosis is bad prognosis, sir. Okay. Prognosis is bad prognosis. Not a good prognosis, bad prognosis, sir. Especially if the liver is involved, there will be bad prognosis. Okay. Next, after this, directly let's discuss about the autosomal dominant polycystic kidney disease. Okay, autosomal dominant. Let's write about the autosomal dominant polycystic kidney disease. Now, देखो, how the kidneys are. Are they smooth kidneys? No, definitely they are not smooth kidneys, sir. Why? Because see, there are multiple number of cysts which are bigger cysts. The kidney is going to be too much enlarged, like a big volleyball. That much size the kidneys are getting enlarged, sir, with multiple number of cysts. No smooth appearance. Gross appearance is not going to be smooth. Okay. Now one more point which I want you to know is, see, this autosomal recessive polycystic kidney disease is there, right? It's also called as juvenile PKD. Okay. Juvenile polycystic kidney disease, because the features, okay, the clinical features are going to be seen from the birth itself. So that's why I'm discussing in the congenital session. Okay, so the features are going to be seen from the birth itself, all these clinical features. But autosomal dominant polycystic kidney disease, I used to remember like adult AD, but actually it is autosomal dominant. Autosomal dominant. But I used to remember like AD, like adult. Because the clinical features will start to manifest from the adulthood. Autosomal dominant polycystic kidney disease. Okay, so here also bilateral cysts are going to be seen in the kidneys. Okay, bilateral cysts are going to be seen in the kidneys. Next, what are the gene mutations involved? Why problem? What is the problem here? What are the gene mutations? Sir, PKD1 polycystic kidney disease gene 1, PKD gene 2, PKD1 and PKD gene 2 mutations. There it is PKHD1 gene mutation. There the protein that is defective is fibrocystin. Here the PKD1 gene and PKD2 gene. PKD1 gene is present on chromosome number 16p. PKD2 is present on chromosome number 4. Okay, chromosome number 4p. Okay, chromosome number 16p and chromosome number 4p. PKD1 gene, PKD2 gene. So because of this gene mutations, what is the protein that's going to be defective? Fibrocystin? No, it's polycystin now. Polycystin 1 protein defect, polycystin 2 defect. Okay, it's a polycystin. Yes, one more, you are true. Polycystin 1 defect as well as polycystin 2 defect. So because of this defect in the polycystin 1 as well as polycystin 2, the patient is going to have multiple cysts. So what are the important points? See, gross features. What are the gross features that you can see? Okay, what are the gross features? Bilaterally enlarged kidneys, right? First, there is going to be bilaterally enlarged kidneys, almost the size of the volleyball, sir. Okay, multiple cysts are going to be present in the both cortex as well as the medulla. Okay, now important point is, they go clinical features. Now in the clinical features, when the clinical features are going to be seen, the patient is going to show the symptoms. Okay, the symptoms are going to be seen in the adult life. So till adult life, no problem, sir. Till adult life, no problem. The symptoms are going to start to manifest from the adult life. What symptoms? The patient is going to have the flank pain. Okay, the patients are going to have the flank pain. That's the earliest clinical manifestation. The patients are going to have the flank pain. Apart from flank pain, what else? Hematuria is going to be seen. Okay, the hematuria is going to be seen. So in these patients, kidney failure, right? In these patients also, there is going to be activation of the RAS pathway. RAS pathway is going to be activated, so that will lead to hypertension. These patients are going to have the hypertension, and these patients are also supposed to have proteinuria. So these are the clinical features, sir. The clinical feature that you can directly ask the patient is the flank pain. The patient is going to have the flank pain, and whenever the patient is going for the urine, red color urine is going to come. That's the hematuria. These patients will show the hypertension and proteinuria is going to be seen, all because of the kidney pathology. Okay. Now important point is, okay sir, kidneys are affected. Okay, good, well and good. Kidneys are affected. Apart from kidneys, what else? The cysts are going to be seen in other organs also, sir. Okay, liver cysts. Okay, the cysts are going to be seen in the other organs. Most commonly, the cysts are going to be seen in liver. Most commonly, cysts are seen in cysts. Are going to be seen in the liver. Apart from liver, organs like pancreas, spleen, okay, pancreas, spleen, lung cysts are also going to be seen, but rare. Okay, lung cysts are going to be rare. So pancreatic cyst. Okay, this is completed. Most common cysts are going to be liver cyst, but yes, pancreatic cyst. Splenic cysts are going to be seen. Okay, pancreatic cyst and splenic cyst are going to be seen. Okay, lung cysts are also going to be seen, but rare. Rare, sir. Now, any other things which are going to be seen. So look here, you can tell me, so what is the structure that I am highlighting here? What is this structure that I am highlighting here? Any idea? Any idea, guys? It's the circle of Willis, right? Now in the circle of Willis, are you able to appreciate there is an aneurysm? So these patients are going to show this berry aneurysm, sir. So it was found out that these patients are going to show berry aneurysms. That will rupture. If that berry aneurysm is ruptured, that's going to cause subarachnoidal hemorrhage with severe headache, thunderclap headache, sir. Okay. Now, heart involvement. Do you know what is the problem in the heart? Do you know what is the problem in the heart? So these patients will have MVP. So what is MVP? Mitral valve prolapse. Mitral valve prolapse is going to be seen. So these are some important points which I want you to know. Berry aneurysms are going to be seen. Mitral valve prolapse with extrarenal cysts. The most common extrarenal cysts are going to be seen in liver cysts. So remember, whenever you see mitral valve prolapse with the berry aneurysms, cysts in the kidney and liver, think about autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. Okay. So these are the points which I want you to know. So these patients are going to have hypertension because of the RAS pathway activation. Okay. These patients are also at risk of infections, kidney infections because of the blockage of the ureters. Okay. Done, sir. Completed. Okay. Next, let's discuss about nephrotic syndrome. Okay, now let's discuss about, so the congenital anomaly is completed. Now let's discuss about the nephrotic syndrome. Important point is autosomal dominant polycystic kidney disease. These patients are also at risk of cancer. Okay, these patients are at risk of complication is cancer, sir. Renal carcinoma. Okay, renal carcinoma, these patients are at risk of developing cancer. Next, apart from that, now let's discuss the most important topic is the nephrotic syndromes. Now my question to you, so what exactly are the nephrotic syndrome? First, okay, look here and tell me, what are the nephrotic syndromes, sir? What exactly are the nephrotic syndrome? Can you tell me? See, nephrotic syndrome is not one disease, it's a syndrome. Okay, now let me take in here page. See, imagine there is this one person. Okay, try to understand. There is this one person, sir. Okay, now in his urine, see, in his urine, if he is losing more than 3.5 grams of protein due to some kidney problem. So due to some kidney pathology, if he is losing more than 3.5 grams of protein every day, then it is called as nephrotic syndrome. Nephrotic syndrome. So yes, of course, one more you are true. It's a proteinuria. Okay, proteinuria. How much proteinuria? See, generally, we will lose proteins in our urine, sir. Some amount of protein loss will be okay. Okay, there is something called as a Tom Horsfall protein. That's present in our urine. In urine, yes, proteins are there. But if you lose more than 3.5 grams of protein in a span of 24 hours, that is in a day, within one day, totally if you lose more than 3.5 grams of protein, yes, you are having nephrotic syndrome. Okay, so first itself I am telling you, look, so there is a disease called as minimal change disease, and one more disease called as focal segmental glomerulosclerosis, membranous glomerulopathy, membranoproliferative glomerulonephritis. Okay, so this disease, all these are the diseases, individual diseases. In all these diseases, one thing is common, sir. More than 3.5 gram of protein loss. Okay, more than 3.5 gram protein loss is going to be seen. Okay, more than 3.5 gram protein loss is going to be seen. So all of them will cause nephrotic syndrome. All of them are examples of nephrotic syndrome. So nephrotic syndrome basically means if there is loss of protein more than 3.5 gram, yes, that's it. That's a nephrotic syndrome. Done. Okay. So now, having said that, let's see some important features in the nephrotic syndrome. Now, definition. What is the definition? The patient is going to lose the proteins in the urine, sir. How much? Okay, in the urine, how much? More than 3.5 grams per day. Okay, more than 3.5 grams per day in 24 hours. So which proteins are going to be lost in the urine? Albumins are losing. The patient is losing the albumins. When the patient is losing the albumins, what happens? What are the clinical features? If I am losing albumin right now, imagine if I am losing the albumin right now, what kind of clinical features are going to be there? Can you tell me, guys? Come on. What kind of right now I am losing the albumin, sir, in my urine. What kind of clinical features are going to be seen in me? Edema. Right. Edema, sir. Okay, hypoalbuminemia. Yes, hypoalbuminemia is going to cause the edema, right? Because of the decrease in the osmotic pressure. The osmotic pressure is going to go down. When the osmotic pressure is going to be decreased, relatively the hydrostatic pressure will be more. That will cause the edema. That's a total different, thing. Pathogenesis is different. But gamma globulins. Sir, what exactly are the gamma globulins? They are also proteins in the blood. They are also going to be lost in the urine. What exactly are the gamma globulins? Sir, gamma globulins are nothing but the antibodies. So, you are continuously losing the antibodies out of your body. When you are losing the antibodies out of your body, that's going to cause infections. So, what is this transferrin? Kya hai? Transferrin, what is transferrin, sir? Transferrin is the iron binding protein, the protein that's going to bind with the iron in the blood. In the blood, iron is bound with transferrin. Okay, so when the transferrin is lost in the blood, when the transferrin is lost in the urine, now the iron binding protein is not there, so that will cause iron deficiency anemia. Okay, that will cause iron deficiency anemia. So, a nephrotic syndrome patient is going to have edema. True. The patient is going to have recurrent infections. True. The patient is going to have iron deficiency anemia. True. Antithrombin 3 is also a protein, sir. Antithrombin, the name itself is there. Antithrombin, antithrombosis, anti-clot. It doesn't form clots, sir. It doesn't allow the intravascular clots to form. Unnecessarily, we don't want any clot to form, sir. Antithrombin 3. But if you lose antithrombin 3, unnecessary clots will start to form in your blood vessels. Okay, unnecessarily clots will start to form in your blood vessels. So what is the risk, sir? The patient is going to have deep venous thrombosis. Okay, so deep venous thrombosis can occur, hypercoagulable states leading to deep venous thrombosis. Now thyroid binding globulins, next one. TBG, thyroid binding globulins. Most important plasma protein that will bind with the T4. Whenever these thyroid binding globulins are not there, that can lead to hypothyroidism. Okay, these are rare but possible. Okay, hypothyroidism will be possible. Now, vitamin D binding protein. Vitamin D binding protein is the one which helps in the binding of the vitamin D. Now, whenever it is not there, so vitamin D deficiency will occur. That will lead to hypocalcemia. Vitamin D normally maintains the blood calcium levels. When vitamin D binding protein is gone, okay, now are you understanding? Vitamin B binding protein. Now, this vitamin D binding protein binds with vitamin D. Now it's binding with the vitamin D. So this vitamin D binding protein is lost in the urine, sir. Along with that, vitamin D will also be lost. When vitamin D is losing out, vitamin D deficiency will happen in the body. That will lead to hypocalcemia and that can lead to rickets. Okay, in the babies. Thyroid binding globulins also same thing. This is the thyroid binding globulins bind with the T4. Okay. Now when they are lost in the urine from the body, thyroid hormones are also getting lost. So that will lead to hypothyroidism. Possible. Okay, like that you need to understand. So these are the clinical features. Now, important point is they are losing proteins, right? Because of some glomerular pathology, okay, because of some pathology, the patient is losing the proteins. True. These patients will not only lose the proteins, but also lose the lipids. Okay, so increase lipids in the blood, sir. Okay, first increase lipids in the blood. We don't know the exact reason. So till today, we don't know the exact reason why. But if I am the person who is suffering with nephrotic syndromes, I used to remember something like this. So proteins are going up out of the body. Now what? When the proteins are not there in the blood, now your liver will think proteins are not there. No. So at least replace the proteins by lipids. We don't know the exact reason why. But in the patient who is suffering with nephrotic syndrome, there will be more production of the lipids by the liver. And the lipids are going to be sent into the blood. So the blood levels of lipids are going to be more. Okay. So increase in the lipids in the blood like LDL. Okay, LDL, especially LDL. LDL cholesterol levels are going to be elevated. HDL cholesterol levels decreases. Now, this LDL will also go out in the, this increased lipids will also go out in the urine. So, increased lipid excretion. Lipids are going to go out in the urine. So, in the urine, what you will see? Lipids are coming out, right? As the lipids are coming out, the lipids, these waxy substances, these lipids, they have to pass through the nephron. So, they will take the shape of the nephron while these lipids when they are coming out in the urine, they will take the shape of the tubule. They will take the shape of the nephron. So you are going to have lipid casts. Okay, so lipid casts are seen in the urine. Now, see, this is the lipid cast. Dekho, this is the lipid cast, sir. These are the lipids which are coming out in the urine. Now, when you put it under the microscope, under the polarized light, now it will show this Maltese cross appearance. These are the lipid molecules showing this Maltese cross. There are different types of crosses, right? Okay, so the Christians wear different types of cross. This is a Maltese cross, sir. Okay, it's a Maltese cross. So Maltese cross appearance is seen in nephrotic syndrome because of this lipids. Lipid casts are going to show the Maltese cross appearance. Okay, look, Maltese cross pattern under the polarized light. Done. So in this one single slide, I have explained you what exactly is a nephrotic syndrome. Nephrotic syndrome means there is a loss of proteins more than 3.5 grams of more than 3.5 grams per day. What are the clinical features? The clinical features are going to be edema. There will be recurrent infections are going to be seen. Vitamin D deficiency can be occurred. Hypothyroidism can be seen. Okay, hypercoagulable states leading to deep venous thrombosis. So in these patients who are suffering with the nephrotic syndrome, we don't know the exact reason why, but the levels of lipids in the blood are going to be increased, especially the LDL cholesterol levels are going to be increased. So these lipids are also going to come out in the urine, lipiduria. So these lipids will take the shape of the tubule, which is called as fatty cast, So now this fatty cast or the waxy cast, when you put it under the microscope, they will show Maltese cross appearance under the polarized light. You know it, right? Okay, so done. After this, now let's begin with the first disease. That is the minimal change disease, sir. Okay, minimal change disease, MCD. We'll simply call it as minimal change disease. Come on, guys. So this minimal change disease, my question to you, I have discussed this in many places. I think even in physiology also. I have discussed this many times. Fun mode, Renuka, Amit Kumar, Vanilla, JMC, Sethi, Usman. Come on, guys. Guys, can you tell me what exactly is the problem in this minimal change disease? Can you tell me what is the most common cause of, can you tell me what is the problem in this minimal change disease? Now think and tell me. Minimal change disease, also called as nil deposit disease, lipoid nephrosis, all are the same names. All are same for the minimal change disease only. Any idea? Let me tell you. Okay, let me tell you one by one. Okay, yeah, fun mode, yes, lipoid nephrosis. Okay, but what is the problem? What exactly is the problem, sir? Same, it's the most common, first of all, let's write one by one important points. Most common cause of nephrotic syndrome. It's the most common cause of nephrotic syndrome. Some of you might have even suffered with this. Okay, it's the most common cause of nephrotic syndrome. It's usually seen in children, sir. Usually seen in children 2 to 5 years of age. Okay, the children. It's usually not seen in adults. Adults, it's uncommon. Now, what is the etiology? Who will get this? Which children, sir? Sir, let me tell you something. Normally, in the glomerular basement membrane, dekho, guys, you should understand this. So this is the glomerular capillary. Easy way of understanding this. This is the glomerular capillary, sir. Okay. Now, what is this one? This is the Bowman's capsule. This is the Bowman's capsule, and this is the proximal convoluted tubule. Bowman's capsule. This is the BC. This is the PCT, proximal convoluted tubule. Now, here, okay, in this area, okay, let me decrease the size of the marker. Decrease. Now, this area, sir. Now, in this area, who is going to be there? Which membrane is going to be there? Glomerular basement membrane. Okay, GBM, glomerular basement membrane is going to be there. Okay, here it is GBM, glomerular basement membrane made up of type 4 collagen. Okay, type 4 collagen. Now, important point, sir. So, this glomerular basement membrane is made up of negative charge. There is going to be negative charge. Okay. Now, even the albumin molecules, see here, dekho, in the blood, albumin molecules are there. Even the albumin molecules are also going to have the negative charge. Okay, albumin molecules are very small molecules. They are very small molecules, but still they have negative charge. So we know from physics, negative charge will repel negativity, like charges will repel, unlike charges will attract. So this negativity will repel the negativity. So normally, The albumin is never going to be filtered. Albumin is never going to be filtered, sir. But do you know what happens? Sir, in this minimal change disease, when the small boy, okay, a 1-year-old boy, when he have infections, okay, infections, for example, respiratory tract infection, respiratory tract infection. Now he is having respiratory tract infection. Or the question can say something like this: the patient have recent vaccination, recent history of vaccination, recent history of the vaccination. Okay. Now tell me, in these people, okay, respiratory tract infections are like, history of immunization or history of vaccination, or this patient is having allergic reaction, atopy. The patient is known to have atopies or allergies. Now in all these conditions, one thing is common, sir. So whenever you have infection, or whenever you take the vaccination, or whenever you have allergy, there is going to be activation of immune system, abnormal activation of the immune system, sir. So there is going to be activation, immune activation. So now in certain individuals, what happens is, so the immune system is activated so much. Now there is too much production of cytokines. Okay, this inflammatory mediator, sir. Too much production of the cytokines. Do you know what these cytokines are going to do? Sir, these cytokines will actually neutralize this negativity. Okay, they will cause neutralization of the glomerular basement membrane negative charge. Okay, so these cytokines, what they will do? They will cause neutralization, or I should say, simply say, there is loss of glomerular basement membrane negative charge. When the glomerular basement membrane negative charge, when it is gone, sir. Okay, what happens? Now look here and tell me, sir, albumins, now are they going to be leaked or not? Now albumins can easily leak. Okay, now these albumin molecules, now they are going to be easily leaked into the Bowman's capsule, just like that, because there is no negativity. Now let me erase the negativity. This negativity is not there. Okay. Now this negativity, just wait, this negativity, it's not there. Okay, for example, this negativity is gone. Because of the loss of this negativity, now the albumin will start to leak into the urine. Okay, now from here, the albumin will come into the urine. So specifically in this minimal change disease, specifically albumins are leaking, not the fibrinogen or not some other proteins, not the globulins. Only albumin is leaking out. So the patient is going to have selective, okay, selective albuminuria. Okay, the patient is going to have selective albuminuria in this small child. The patient is losing the albumin out. Whenever the patient is losing the albumin out, what are the clinical features that are going to be seen? What are the clinical features that are going to be seen, sir? The patient is going to show periorbital edema. The losing the albumin out of the body, right? So he is going to show the edema, first feature. So the baby is going to show periorbital edema. Okay, not only the periorbital edema, the proteins are going out in the urine. So what kind of urine he is going to be produce? What kind of urine he is going to produce, sir? It's a frothy urine. There are so much albumins in the urine, so the urine is going to be bubbly. Okay, a lot of bubbles are going to be seen. Frothy urine is going to be seen. Okay, frothy urine is going to be seen, sir, by the baby. Now tell me, sir, this minimal change disease, see, it's a nil deposit disease. See, minimal change. What is that minimal change that is happening? So the minimal change that happens is the loss of glomerular basement membrane negative charge. Okay, so it's a nil deposit disease, sir. No deposit, no immune complexes are getting deposited over there. No immune complexes, no antigen antibody complexes are getting deposited in the kidney. Immune complexes are deposited in different diseases, but here there are no immune complexes. So that's why it is called as a nil deposit disease. Now it is seen in children or adults? Mainly seen in the children of 2 to 5 years, sir. Usually the question that will be given in your exam is a child with a recent history of upper respiratory tract infection, or the child who have recent history of vaccination or immunization, or a child who had allergic reaction, atopy. After this episode, now the patient have developed periorbital edema and frothy urine. Think about minimal change disease. Okay, think about the minimal change disease. Now, what else you should know? Okay, what else you should know here is, sir, this minimal change disease, yes, it's of course, it's mainly seen in the children. But even adult can have this minimal change disease. Even adults can have minimal change disease. Which adults, sir? Which adults can have this minimal change disease? So those adults who is having some cancers like Hodgkin's lymphoma. Hodgkin's lymphoma. So adults who are having this Hodgkin's lymphoma can develop minimal change disease too. Okay, most of the time in adults it is idiopathic, we don't know. Yeah, adults can develop, but we don't know the reason, idiopathic. But those adults who are having this Hodgkin's lymphoma cancer, okay, WBC cancer, they can develop minimal change disease. So in this condition, okay, hematuria is there, blood loss in the urine, hematuria is there, no hematuria. Okay, no hematuria. Hypertension is there in the baby, no hypertension. Hematuria, hypertension, they are not there, sir. Because hematuria and hypertension, these are the things which are seen in nephritic syndromes. They are different. Nephritic syndromes are different. These are nephrotic. These are nephrotic syndromes where proteinuria is more dominant. Okay. So these are some important points which I want you to know. In the urine, you can see the proteinuria. Okay, and even lipids are, it's a nephrotic syndrome, right? Even lipids are also going to come out in the urine. Okay, minimal change disease. Let me write important points. Okay. So diagnosis, sir. In the diagnosis, what you will see? Albumin levels in the blood. Albumin levels are going to come down. What happened to the lipid levels? I have explained you, LDL cholesterol increases, lipids. Lipid levels will start to increase. Now the complement levels, C3 levels, complement levels are going to be normal. Why? Because there are certain diseases, later on you will understand. C3 levels are going to go down in certain type of nephrotic syndromes, but this is the nephrotic syndrome where the complement levels are normal. The complement levels are in normal range. Okay. So next in urine, this is what is seen in the blood, sir. Okay, this is what is seen in the blood. In the urine, what you will see? See, in the urine, the patient is going to show proteinuria or albuminuria and also lipid cast. The patient is going to have lipid casts are going to be seen. Done. Okay. After this, so the microscopic findings. Now let's discuss about the light microscopy. Let's discuss about immunofluorescence microscopy and electron microscopy. Sir, under these microscopes, what you will see in minimal change disease? In this minimal change disease, what you will see under the light microscope? You take the kidney biopsy. Okay, you take the kidney biopsy and you put it under the microscope and you are just seeing. Sir, it's a minimal change disease. Nothing is changing, sir, in the kidney. Everything is normal. Just that negative charge is lost and there is one more change there that I will explain you. Okay. In light microscopy, nothing is visible. Normal. Okay, normal. It's going to be normal, sir. No deformity is visible. Okay. So that's why it is called as a minimal change disease. Immunofluorescence. Sir, immunofluorescence normally shows what? Immune complexes. If immune complexes are there, there will be fluorescence. There will be fluorescence if the immune complexes are deposited in the kidney. Now, in this condition, there are no immune complexes. So, immunofluorescence is going to be negative. Okay, negative immunofluorescence. No antigen antibody complexes. No immune complexes. But electron microscopy, sir. Now, if you look at the electron microscopy, what you can say is, sir, the podocytic food processes. Okay, in minimal change disease, the podocytic food processes, they are effaced. Okay, that's the one thing which is seen under the electron microscopy. So that's the best investigation of choice. Okay, there is loss of podocytic. Now students will have it out, sir. What is this podocytic? I will explain you. Podocytic food processes. Or podocytic, like effacement of the podocytic food process. They will say, they will also use the word effacement. Effacement of podocytic food processes. Now students will have it out, sir. What are these podocytic food processes? Like if you have studied your physiology, then you would have podocytopathy. Yes, true. So if you have studied your physiology, then it will be easy for you. So देखो guys, now this is the Bowman's capsule, right? Let me show you. Sir, here Bowman's capsule, here there are these cells, sir. These are the cells which are present here. These are the epithelial cells actually, these are the epithelial cells. Now these epithelial cells which I am drawing here, see these are they are having these legs, right? They are having these leg-like processes. These are called as the foot processes. And the cells which I have drawn now, these are the podocytes. These are the podocytes. Podocytes are the visceral epithelial cells. These are the visceral epithelial cells in the Bowman's capsule. These are the podocytes. Okay. In this condition, what happens is these podocytic foot processes are going to be effaced, lost. Okay, that's what is seen in minimal change disease. Beg your pardon. So, loss of podocytic foot processes. That's what is seen. Now, next, what is the treatment that is done in this condition? What is the treatment? Sir, now this small boy is having all these problems, proteinuria, periorbital edema. Okay. Now, how to treat this condition? So, the drug of choice in this condition is steroids. Steroids show excellent prognosis. If you use the steroids, the prognosis is going to be excellent. Okay. So, every book mentions that the steroids shows the excellent prognosis. Why? Because steroids are what? Steroids are the immunosuppressants. The main problem in this condition is immune activation, overactivation, over-immune activation. So that's the problem, right? Now, what is the problem? The problem is too much activation of the immune system. So when you give steroids, what steroids will do? Steroids are the immunosuppressants. They will suppress the immune system. So the problem is going to be treated. So completed? Completed? Okay. Next. Second type of nephrotic syndrome. Okay, second type of nephrotic syndrome that I am going to discuss here is, look here, what is this disease? Focal segmental glomerulosclerosis. Let me explain this in next 10 minutes. Simple, but very, very important. Very, very important. Sir, minimal change disease is the most common cause of nephrotic syndrome in the children. Then what is the most common cause of nephrotic syndrome in the adults like us? It's the focal segmental glomerulosclerosis. Okay, so what exactly is FSGS, sir? The word FSGS stands what? FSGS. It stands for what? Focal. What exactly is focal? What is segmental? I will explain. Focal means few glomeruli are affected, not the entire glomeruli. Okay, say for example in a kidney there are, for example, 1 million glomeruli, for example. Okay, do you think all 1 million glomeruli are going to be affected? No, sir. All 1 million glomeruli are not going to be affected. Some glomeruli are affected. Focal means few glomeruli are affected. What exactly segmental kya hai? What exactly is segmental? Even in the affected glomeruli, for example, in that 1 million glomeruli, for example, 1000 glomeruli are affected. Even in this the glomeruli, see this is the one of the affected glomeruli. This is one of the affected glomeruli. Even in this affected glomeruli, not the entire glomerulus is affected. One part of the glomerulus is affected. So segmental. Okay, affected glomeruli are not completely involved. There is a patchy involvement. Okay, let me show you that image. In the image also, this is a healthy glomerulus. This is a healthy glomerulus. Okay, we can very clearly see this is the image-based question which was asked in the NEET PG exam. They gave this histology and I have asked, what is the structure? Histology, sir. It's a Bowman's capsule. It's the glomeruli. Okay, now here what is happening? Sir, this is also same Bowman's capsule glomeruli, but are you able to appreciate this part of the glomeruli is sclerosed, total pinkish depositions are gone, damaged. So it is a segmental. Okay, so focal, segmental, glomerulosclerosis. Glomeruli is getting sclerosed, hardened because of the damage with the collagen deposition over there. Okay, so focal completed. Segmental completed. Focal segmental glomerulosclerosis. And I have explained you FSGS is the most common cause of what? It's the most common cause of nephrotic syndrome in the adults. In the children it is that minimal change disease, right? Now, what are the causes, sir? The causes are divided into 3 types. The primary means we don't know why it is happening. The most common cause is the idiopathic, sir. The primary means we don't know why it is happening in the adults. We don't know. Or secondary. Secondary means acquired. Okay. Acquired means you got it. Okay, you got it. You have acquired it. Means, see, HIV, is it going to be congenital? No, it's going to be acquired. See, of course, yes, in certain cases, yes, it may be. Now, HIV means acquired disease, right? Okay, you have got it. You got it, sir. As a prize, you got it because of your actions. Now, whenever you are having HIV, multiple organs are going to be affected. Even kidneys will be affected with this virus. If kidneys are affected, which type of involvement, sir? How the kidneys are going to be affected? Focal segmental glomerular sclerosis is going to occur for the kidneys. Okay, so HIV individuals are going to have kidney problems. Which kidney problem? Focal segmental glomerular sclerosis, nephrotic syndrome. Kidneys are getting affected. Or IV drug abuse. So, if you are doing IV drug abuse, okay, because like you are using drugs like heroin. Okay, sir. When you do this IV drug abuse, again your kidneys are going to be banged. Okay, your kidneys are going to be banged up. So, how the kidneys are going to be affected? Focal segmental glomerular sclerosis. Sickle cell anemia patients, kidneys will be affected because of the blockage of the blood to the kidneys. Multiple things will happen, but generally speaking, sickle cell anemia patients can develop FSGS, visco-ureteral reflux. Okay, visco-ureteral reflux. Now, what exactly is this vesico-ureteral reflux? Vesico-ureteral reflux means the reflux nephropathy, sir. Reflux nephropathy. Say, look here. Imagine this is the kidney. Now, from the kidney, these are the ureters. Now, from here, what is this? This is the bladder. From here, this is the urethra. Now, in certain individuals, what happens is, sir, from here, the urine which is there in the bladder, this urine, it will go back. It will go back into the ureters. It will go back up to the renal pelvis. Means reflux. Vesico, from the vesicle. Vesicle means the bladder. From the vesicle into the ureters. Vesico-ureteral reflux. The urine is getting back into the kidney again. So again, kidneys are going to be damaged, sir. Which type of kidney damage? Focal segmental glomerular sclerosis. Done. And hypertension nephropathy. Okay, the patient is having hypertension that can lead to nephropathy, hypertension nephropathies. Okay, unilateral renal agenesis. I have discussed in the beginning. Unilateral renal agenesis. In the remaining kidney, in the leftover kidney, there will be glomerular sclerosis. Let me show you. Okay, sir, this is what we have discussed, right? So whenever the left kidney is absent, whenever the left kidney is absent, there is compensatory right kidney hyperplasia. Now in this right kidney, what you will see? Glomerulosclerosis, focal segmental glomerulosclerosis, sir. Unilateral renal agenesis possible. Okay, because all the work is done by one single kidney, the glomerulus are going to be damaged, healed with fibrosis. So focal segmental glomerular sclerosis, hardening. Okay, so now tell me what are the causes? What are the causes of focal segmental glomerular sclerosis? Primary cause is idiopathic, we don't know. There are secondary causes which are acquired causes like HIV, IV drug abuse, visco-ureteral reflux, hypertension nephropathy, sickle cell anemias, and unilateral renal agenesis. Okay, these are some important causes. Okay, these are some important causes which I want you to know. Since sometimes, okay, this focal segmental glomerular sclerosis is hereditary in nature. Hereditary in nature. Okay, it is hereditary in nature. Okay, hereditary in nature, sir. Okay, it is hereditary in nature. Now, hereditary in nature in the sense what? Families, it's running in the families because of certain gene mutation. NPHS1 gene mutation, NPHS2 gene mutation. Okay, NPHS2 gene mutation gone. Okay, enough. These are enough. So at least for your exam, I want you to know these two things. Sir, NPHS1 gene mutation and NPHS2 gene mutation, what they will do, I will explain you in detail. Okay, what they will do, I will explain you in detail, sir. But for now, trust me, sir, NPHS1 gene mutation, NPHS2 gene mutation, they will cause focal segmental glomerular sclerosis in families. Okay, hereditary in nature. Okay, done. So now let me tell you what is that NPHS1, NPHS2. Okay, guys, look here. Say this is the blood vessel, glomerular capillary. This is the glomerular capillary, sir. Imagine that's the blood vessel, glomerular capillary. Okay, now you know this thing, right? Okay, I hope you guys, most of you guys know this. So this is the glomerular capillary. Down to the glomerular capillary, what is there? So this is the glomerular basement membrane. Let me show in a small size. Okay, this is the glomerular basement membrane made up of type 4 collagen. Now down to it, there is Bowman's capsule. Here is the Bowman's capsule. Normal filtration will occur like this, right? You know it. Okay. Now, let me tell you, see. So these are which cells? Can you tell me these are which cells? Sir, here I am showing you podocytes in a simple way. In a simple way, I am showing you what? So these are the podocytes. Right? These are the podocytes. Visceral epithelial cells, podocytes. Actually, in between the podocytes, okay, in between the podocytes, there are these proteins present. In between the podocytes, they go. Sir, there is this structure present, sir, made up of certain proteins. Do you know what is this structure? Guys, do you know what is the structure that I am showing you here in red color? So this is called as slit diaphragm. Slit diaphragm. Slit diaphragm, sir. Now that slit diaphragm, it's made up of certain proteins. Now tell me, so this slit diaphragm, it's acting like a gate, right? It's actually acting like a gate. Okay, it's also acting like a gate for the entry of substances into the Bowman's capsule. For example, see, now if this gate is damaged, now let's try to understand like this. So, देखो, now this gate is damaged, so because of some reason, the gate is gone. Okay, now that slit diaphragm is gone, sir. When that slit diaphragm is gone, now proteins will start to leak down. Okay, the macromolecules like proteins, now they will start to filter down. So that's what happens whenever there is damage to this slit diaphragm. So important, sir, slit diaphragm is very important. The slit diaphragm is made up of what? The slit diaphragm is made up of important proteins. What are they? See, देखो, here also see. So these are the podocytes. These are the podocytes. All these are the podocytes. I am showing in a reverse direction. Reverse direction. This is the glomerular capillary. This is the glomerular basement membrane. Other side of the glomerular basement membrane, what are these? These are the podocytes. In between the podocytes, are you able to appreciate the structure? What is that, sir? The structure, it's called as slit diaphragm. It's called as a slit diaphragm. Slit diaphragm is made up of what? Podocin, nephrin. Okay, podocin and nephrin. So this podocin and nephrin, they are coded by certain genes, sir. Podocin as well as the nephrin. So this nephrin is coded by NPHS1. NPHS1 gene. This podocin, it is coded by NPHS2 gene. NPHS1 as well as NPHS2. Important. NPHS1 code for nephrin. NPHS2 codes for podocin. Now, see, this NPHS1 is gone. So when NPHS1 is damaged, okay, gone, mutated, nephrin is not going to be produced normally. So slit diaphragm is not going to be there normally. So protein loss. So it's causing which type of nephrotic syndrome? Focal segmental glomerulosclerosis only, but it is going to be there by birth. So it is called as congenital nephrotic syndrome. Okay, right. So by birth it is there. So congenital nephrotic. So it is called as the congenital nephrotic syndrome of Finnish type. Okay, congenital nephrotic syndrome of the Finnish type. Okay, so this was a question which was asked many times. Okay, many times. Congenital nephrotic syndrome of the Finnish type. It is seen due to mutation of NPHS1. Okay, NPHS1. NPHS2 gene mutation. For example, if this NPHS2 gene is mutated, this protein is going to be defective. Podocin protein is going to be defective. When podocin, if it is defective, it is also going to cause damage to the slit diaphragm. Okay, but it will cause different type of FSGS, different variant of FSGS. This is called as steroid resistant nephrotic syndrome. Steroid resistant nephrotic syndrome of childhood onset. So both are going to be there from childhood onset. Okay, both are going to be there from childhood itself. Okay, congenital nephrotic syndrome of Finnish type or steroid resistant nephrotic syndrome of childhood onset, both are going to be there from by birth itself. But the genes mutated are different. NPHS1 gene mutation, NPHS2 gene mutation. Proteins that are defective are different. One is the nephrin defect, another is the podocin defect. Okay, so both this steroid resistant nephrotic syndrome as well as congenital nephrotic syndrome of Finnish type, both are a type of FSGS. Both are a type of FSGS, sir. Okay, so that's the point which I want you to know. Okay, now apart from this, what else have asked in the exam? So far, what else were asked in the what else are asked in the exam, sir? So, is there any immune complex deposition in this condition? So, immunofluorescence. Okay, immunofluorescence is going to be negative. No immune complexes. Even in MCD, minimal change disease also no immune complexes. Focal segment glomerular sclerosis also no immune complexes. Why I am saying this specifically? Because there are different types of nephrotic syndrome. There are other nephrotic syndromes you will study. They are due to immune complex deposition. Okay. Now what else will be seen here in this condition also? Okay, under the microscopy, okay, under the microscopic examination, what will be seen here also? Podocytic food processes are going to be damaged. Podocytic food process are damaged due to damage of the podocytic food processes. The proteins are going out in the urine. So, is it only albumin going now in this condition? No, sir. It's not just albumin. Albumin, globulin, fibrinogen, all other proteins are going. So, it is non-selective proteinuria. Okay, this is little severe. Non-selective proteinuria, sir. Okay, it's going to be non-selective proteinuria. So, these patients are at a risk of renal failure. So, renal failure will occur. Renal failure will occur in 10 years. Okay, in 10 years, kidneys are going to be totally damaged. Renal failure will occur in the 10 years. Okay, that's the important point. Next important point is, dekho, histological variants they will ask you. Histological variants. Okay. Histological variants. There are different types of FSGS. Actually, dekho, there is perihilar variant, glomerular tip lesion, collapsing variant and cellular variant based on the histological appearance. Which part of the glomerulus is getting affected? Which part of the glomerulus is getting affected? Based on that, there are different types of histological variants like perihilar variant, collapsing variant, okay, glomerular tip variant, cellular variant, different types, 4 types are there. Not everything is important. What is important for you, for your exam is which one is having good prognosis? Which variant is having good prognosis? See, only glomerular tip variant, only glomerular tip is affected. So, glomerular tip variant is having good prognosis. Then who is having bad prognosis? See, I am giving you chance. Now you think and tell me. Sir, perihilar variant, tip variant, collapsing variant and cellular variant. What is looking more dangerous? Collapsing. Okay, so bad prognosis is therefore collapsing variant. Okay, collapsing variant is going to have a bad prognosis. Now, do you know who will get the collapsing variant of FSGS? Collapsing variant type of FSGS. See, there are different causes, right? You know the causes of FSGS. Okay, HIV, IV drug abuse, sickle cell anemia, viscoerythral reflex, hypertension, nephropathy, unilateral renal agenesis, and there are hereditary causes also, you know it. Now, which people will develop collapsing type of focal segmental glomerular sclerosis? Do you know? What do you think? It's more dangerous, right? What do you think is more dangerous out of all this? What do you think? More dangerous conditions, sir. Everyone is fearing of. Okay, feared of. What do you think? HIV. Yes, one more, you are true. Okay. So, this bad prognosis is there for collapsing variant which is associated with HIV. Okay, HIV is a collapsing variant, shows the poor prognosis that associated with HIV, and especially if you use certain drugs like bisphosphonates. Okay, bisphosphonates. Okay, these drugs also. These bisphosphonates, sir, they are actually a drug of choice for osteoporosis. For osteoporosis treatment, you use the bisphosphonate drugs, but if you use these bisphosphonate drugs, that will also cause focal segmental glomerular sclerosis. One point which I want you to know. Okay, and the chances of renal failure in this condition, like generally speaking, focal segmental glomerular sclerosis, renal failure chances are going to be high. In 10 years, I have explained, in 10 years, there is a risk of renal failure. Okay, so treatment with steroids, not possible, poor response. But minimal change disease show excellent response with the steroids, but here steroids are not going to work. Okay, steroids are not going to work. These patients usually go for the transplant. Okay, so 2 types of nephrotic syndromes are completed. Now, now after this, let's discuss about one more nephrotic syndrome and let's stop for today. Okay, one more nephrotic syndrome, sir. The next nephrotic syndrome that I am going to discuss here is membranous nephropathy. Okay, membranous nephropathy. Answer my questions. What is the most common cause of nephrotic syndrome in children? Sir, the most common cause of nephrotic syndrome in children is minimal change disease. What is the most common cause of nephrotic syndrome in adults? Sir, it is focal segmental glomerular sclerosis. Then what is the most common cause of nephrotic syndrome in elderly? Membranous glomerulopathy. Okay, so right, it's the most common cause of nephrotic syndrome. Yes, one more, you are true. The most common cause of nephrotic syndrome in elderly, sir, in geriatric population. Okay, it's a membranous nephropathy. Okay, not only that, it's the most common cause of nephrotic syndrome in a patient who is suffering with SLE, systemic lupus erythematosus, autoimmune disease, sir. Okay, in SLE patients also it's a thing, and it's also the most common cause of nephrotic syndrome in a patient who is suffering with hepatitis B. Especially children who are suffering with hepatitis B, they can go into the kidney related problems. That's the membranous glomerulopathy. Okay, and it's also most common cause of nephrotic syndrome in patients who are suffering with solid tumors. What are solid tumors, sir? Okay, solid tumors, what exactly are they? The solid tumors means, not, see, liquid tumors, you know it's a blood cancer. Okay, leukemias. But solid tumors means, for example, melanoma, colon cancer, lung cancer, breast cancer. Okay, like melanoma. Okay, melanoma, lung cancer, colon cancer, and breast cancer. Okay, so these are the solid tumors, right? They are not liquid tumors. Just generally speaking, all solid tumors. So those patients who are suffering with the solid tumors, they are at risk of developing which type of nephrotic syndrome? It's a minimal change disease. Okay. Now, etiology, here also same thing. Etiology. Let me write etiology here. Etiology. Primary means idiopathic. We don't know why it is happening. Majority of the cases of MCD are, we don't know, sir. Primary, there is the most common, that is idiopathic. Secondaries, you know it. Secondaries are acquired. Okay, secondaries are acquired. Which patients will get this, the secondaries? Solid tumors, those who have solid tumors. Okay, those who have solid tumors are those who develop the SLE, systemic lupus erythematosus, are those who have infections like hepatitis B infection or hepatitis C infection. Okay, so those who have infections like malaria. Okay, those who have malaria. Spelling mistake. Okay, or infections with organisms like syphilis, schistosomiasis. Okay, these infections. Okay, schistosomiasis. Okay, so these infections are. So these are the secondaries. The primary causes we don't know. We don't know the primary causes. The most common cause is the primary cause, idiopathic. We don't know why it is happening. Secondary causes like those who have solid tumors or those who have infections with syphilis, schistosomiasis or malaria. Those who have autoimmune conditions like SLE. Okay, so they can develop. Okay, they can develop this membranous glomerulopathy. True. Now, what's the problem in this membranous glomerulopathy? What's the problem, sir? See, here the problem is, let me write one by one, you will understand. So these patients, they produce autoantibodies. Okay, autoantibodies, right? First, it's an autoimmune thing, autoantibodies. IgG. See, IgG autoantibodies are going to be produced, IgG4 antibodies. Okay, see these IgG4 antibodies, they will target the antigen targets Antigens. Do you know what is the antigen in this condition? The antigen in this condition is phospholipase A2 receptor. Phospholipase A2 receptor, which is present in the glomerulus. Okay, which is present, actually it is present in the podocytes. That's the problem. So, in this membranous glomerulopathy, what exactly is happening is this IgG4 autoantibodies are produced against the phospholipase A2, which is present in visceral epithelial cells, that's the podocytes. Okay, now what happens because of this? The podocytes are going to be damaged, podocyte damage. Podocytes are going to be damaged. If the podocytes are damaged, what will happen? There will be non-selective proteinuria. So non-selective proteinuria leading to nephrotic syndrome. So as simple as that, simple. So it's almost an autoimmune disease. Okay, autoantibodies, that's IgG4 antibodies are produced against the phospholipase A2 receptor. So that's leading to the podocyte damage, leading to nephrotic syndrome. Okay. Now, if you look at the blood, okay, in membranous glomerulopathy, see, these are the immune things, right? These are the immune things. Okay, immune antibodies are involved. Antibodies are going and attacking what? The antibodies are going and attacking the phospholipase A2 receptor. The immune complexes are involved here. Antigen antibody complex is there. Antigen is phospholipase A2. The antibody is going and getting deposited over there. So it's an immune complex disease. Immune complex and mediated disease. Okay. Immune complexes are present. Yes, immune complex mediated. Immune complexes are present. Now, because of that, when you do immunofluorescence, okay, when you take a tissue biopsy, and when you go for the immunofluorescence study, how the immunofluorescence study is going to look like? It's going to fluorescent. Lightning is coming. Okay, so now these patients are going to have, whenever you do the immunofluorescence, granular immunofluorescence is seen. Granular immunofluorescence, like granules here and there, the immune complexes are deposited, and those immune complexes are giving the fluorescence light. Okay. Now, in the blood, what you will see? Sir, in the blood, when you take the blood sample of this patient, what you will see? You will see the antibodies. Which antibodies? The patient is going to have phospholipase A2 receptor antibodies. Okay, phospholipase A2 receptor antibodies are going to be seen, sir. Okay. Under electron microscopy, what is seen? Okay, under electron microscopy, what is seen? Because the immune complexes are deposited. The immune complexes, the antibodies are going and attacking the phospholipase A2. See, in the glomerular basement membrane, are you able to look at these immune complexes? All these are the immune complexes, sir. Okay, these are the immune complexes. Because of that, are you able to appreciate this pattern? Okay, are you able to appreciate this pattern? This is a spike and dome pattern. Okay, spike and dome appearance. Okay, due to deposition of this immune complexes. Okay, let me write due to subepithelial, means the deposits are going to go and deposit under the epithelial cells. Under the epithelial cells. Which epithelial cells? Podocytes. Okay, so there will be subepithelial immune complex deposits. Okay, subepithelial immune complex deposits giving spike and dome pattern to the glomerular basement membrane. Spike and dome pattern. Okay, this is the question which was asked in recent PG exam. Spike and dome pattern. Okay, even here you can clearly see, sir, these are the immune complexes. So like a spike and dome pattern can be seen, sir. Spike and dome appearance of the glomerular basement membrane can be seen. Here also you can see these are all the immune complexes. Okay, so these are some important points which I want you to know. The immunofluorescence will show subepithelial. Immunofluorescence will show the granular. Okay, granular immunofluorescence. The antibodies. See, antibodies are going to be phospholipase receptor A2 antibodies. Under electron microscopy, there will be subepithelial immune complex deposits are going to be seen. Spike and dome pattern. Okay. So now if you ask me, sir, why this disease is called as a membranous glomerulopathy? Why it is called as membranous glomerulopathy? Because in this diseases, actually I forgot to show you the like histological image, but anyway, there is thickening of the glomerular basement membrane. That this thickening, so the glomerular basement membrane is going to be thickened. So that's why membranous. What is this membranous? The glomerular basement membrane. Okay, let me write here. There is thickening of glomerular basement membrane. Tomorrow I will show you. There is thickening of the glomerular basement membrane in this disease. Okay, so these are some important points which I want you to know. Okay, so this is also going to show the poor response to steroids. One more very important point I have forgot. So if there is a person, okay, complications, right? Okay, complications. If there is a person who is suffering with this minimal change disease, okay, now he is at a risk of what? His general clinical features are there, like proteinuria is going to be seen, edema is going to be seen, excessive frothiness of the urine is going to be seen, non-selective proteinuria. That's common things. But these patients are at a high risk of, very high risk of, right? Very high risk. Proteinuria is there, severe, excessive, massive proteinuria is going to be there. So these patients are at a very high risk of deep venous thrombosis, renal artery thrombosis. Okay, renal artery thrombosis, mainly they will say renal vein thrombosis, sir. Okay, deep venous thrombosis, renal vein thrombosis, and even pulmonary thromboembolism. Maximum risk. This was the question which was asked many times previously. Which nephrotic syndrome have maximum risk of deep venous thrombosis or pulmonary venous thrombosis or renal vein thrombosis? It is membranous nephropathy. You know it, right? Nephrotic syndromes, antithrombin 3 is going to go out, hypercoagulable states. Whenever there is hypercoagulable state, there is a risk of deep venous thrombosis. I have explained you. So which nephrotic syndrome have highest risk of renal vein thrombosis? This is the question which was repeatedly asked. Renal vein thrombosis. It's the membranous nephropathy. Okay, so these patients also, there is a poor response to the steroids. These patients also go for the transplant. Okay, these patients also go for the transplant. Even after transplant, okay, in 40% of the cases it will recur, sir. Again it will reoccur even after the transplant. Okay, so these are the important points about the membranous nephropathy. If you know this much, this is enough. There is something like historical fact like megalin antigen, that's not that important. But if you know this much, till here this complication is very important. Okay, complication associated with hepatitis B, associated with hepatitis B, hepatitis C, associated with HLE, most common nephropathy in the elderly. Okay, thickening of the glomerular basement membrane, immunofluorescence shows granular deposits, spike and dome pattern, subepithelial deposits, immune complex mediated, autoantibodies produced, IgG4 autoantibodies are produced against the phospholipase receptor A2. Okay, phospholipase A2 receptor, that's the antigen. So these are all some important points. If you know this much, enough. Tomorrow, let's continue with the other nephrotic syndromes. Membranoproliferative glomerulonephritis is there. Okay, MPGN type 1, MPGN type 2. Tomorrow we'll continue with that. Okay, hope the video is helpful. Tomorrow most probably our class is going to be in the morning. Okay, most probably in the morning or in the evening, not in the, morning or afternoon, not in the evening, sir. Okay, most probably the class will be in the morning, that you will get the notification. Okay, guys, hope the class is helpful. See you tomorrow. Good night.